Most people assume that when something in medicine is broken, it must be broken somewhere far away, somewhere underfunded, somewhere understaffed. But the most dangerous failures often happen in places we trust the most, places with reputation, prestige, and confidence. That's what I want to talk about today. I want to start by being very clear about who I am and who I'm not. I'm not retired. I'm not consulting from the sidelines. I'm not reflecting on medicine from memory. I practice obstetrics now. I write prescriptions now. I'm in the hospital now. Every week, I'm caring for real women with real pregnancies, making real decisions that matter. So what I'm about to say isn't theory, it's lived, daily practice. Maternal health care is broken, not just in remote places, not just in under-resourced communities, even here, even in Boston. I trained here. I've spent my entire medical career here in what many consider a mecca of medicine. Boston is where people come for second opinions, for rare diagnosis, for cutting-edge care. And I say this with clarity, not criticism. Boston is no exception when it comes to the shortcomings of modern maternal care. This isn't about bad doctors. This isn't about blaming nurses. This isn't about lack of intelligence or dedication. Most people working in maternity care are thoughtful, hardworking, and well-intentioned. The problem is structural. The system itself no longer matches the reality of the patients it serves. I came to the United States in mid-1970s. Back then, cesarean section rate was about 5%. Epidurals were rare. Continuous fetal heart monitoring was uncommon. Birth was attended differently. Decision-making was slower. Intervention existed, but it was restrained. The average woman of reproductive age was about 5'3" and weighed around 140 pounds. There were fewer chronic medical conditions, fewer medications, less baseline medical complexity. This isn't nostalgia. It's not romanticizing the past. Medicine has saved countless lives since then. Technology has absolutely improved outcomes in high-risk situations. But here's what changed quietly and profoundly. Fast forward to today. The C-section rate is now about 1 in 3. Epidural use exceeds 70% nationally. Continuous monitoring is routine. The average height hasn't changed much, but the average weight has increased significantly, now closer to mid-170 pounds. We see more hypertension, more diabetes, more autoimmune disease, more anxiety and depression. Many patients enter pregnancy already managing multiple medical conditions. Many are taking several prescription medications. And here's the critical point. We now intervene more than ever while caring for a population that is objectively less healthy. Yet the approach hasn't fundamentally changed. This is where the system breaks down. We built obstetrics for resilience. We're now practicing it in an era of chronic stress, metabolic dysfunction, and fear-based care. So what happens? Risk goes up. Fear follows. Fear leads to protocols. Protocols reduce nuance. And reduced nuance leads to reflexive intervention. But pregnancy is not binary. It's not safe or unsafe, normal or abnormal. It lives in the gray. And when medicine loses comfort with the gray, it reaches for control. Here's the key distinction that often gets lost. More intervention does not automatically mean better care. Sometimes it means earlier decisions made with less information. This is what I mean by just-in-case medicine. Just-in-case medicine is driven by what might happen, not by what is happening. It's shaped by insurance requirements, liability concerns, guidelines treated as rules instead of tools, burnout, and systems designed for efficiency, not reflection. I understand why it exists. No one wants to miss something. No one wants a bad outcome. But when fear becomes the organizing principle, patients feel it. Decisions feel rushed. Options feel limited. Questions feel unwelcome. And here's the line I want you to remember. Just-in-case medicine feels safe for the system, but not always for the patient. The downstream effects are everywhere. Infection rates continue to rise. Primary C-section rates remain high. Trust erodes. Women tell me they feel powerless. They feel talked at, not talked with. They feel like decisions are happening to them. And I want to be very clear about this. Birth trauma doesn't come from emergencies. Emergencies require action, and most people understand that. Trauma comes from feeling like things are happening to you, not with you, from not being heard, from not understanding why something is happening. Despite all of this, good outcomes are still possible. Not through perfection, not through controlling every variable, but through alignment. I call this the holy trinity of pregnancy. First, education, not internet panic, but real understanding of pregnancy, wellness, and the medical system. Second, the right provider, not perfect, not famous, but aligned in philosophy and communication. Third, doula support. Support that spans pregnancy, labor, and postpartum. And here's the key truth. You don't need all three, but you need at least two. That combination changes how decisions are made and how they feel. In the next episodes, I'm going to slow this down and go deeper. How we got here. Why fear replaced trust. And what actually helps without slogans or promises. This isn't about rejecting medicine. It's about practicing it with humility. And humility starts with listening.